Okay, so what I'm going to do is I'm going to just set the scene for the day, and it's really great, because I don't know, you can correct me, I don't know how many events have been in the past where we're trying to gather all the district nurses and as many of the practice nurses together for a beginning of a conversation and how we might work better together. Well, I think this needs to be the beginning of something rather than as a one-off. So I'm going to just set the scene really, and I'm going to paint a picture of how things are evolving and emerging and the changes that are happening. But I'm starting with this slide, and some of you might have seen this, but this is a sort of classic public health slide of what makes us healthy. And I use this to remind ourselves, we went to visit the States about 2 years ago and went around the Veterans Association hospitals in America, and the chief exec was famous for saying, Ken Kaiser was famous for saying to his staff, what business are we in? And people would say, oh, well, we deliver hospital services, or we're in cancer care, and then they would ask again, what business are we in? And the answer he was trying to prompt is that we're in the business of the health and well-being of our populations. So if we think of us collectively as public servants, really, that we're not, if we think of what we're doing in just very narrow terms of delivering services, we miss the point for a lot of people, because when you actually think about what makes people healthy, there's healthcare services that we all work in, but it's just one element of what makes somebody healthy. So, you know, there's age, sex, hereditary factors, your lifestyle factors, the community network. So most of you will know that if you're socially isolated, your mortality risk goes up. There's a meta-analysis done in the States in 2010 that looked at this very carefully, and your risk of excess mortality related to social isolation was equivalent to smoking about 15 a day. So, you know, right up there, if it was a health parameter, we'd be doing massive programs against social isolation. So all these different, you know, and if you're alone, if you live in poor housing, we have excess deaths every winter because of poor housing stock. So that's the business I think we should collectively think of ourselves as being in. So what we've got in Cumbria, we've got 81 GP practices with 81 nurse teams, 81 practice managers, 81 you know, people leading on quality and safeguarding, 81 safeguarding leads. We've got 46 district nurse teams in the Partnership Trust. We've got probably 100 to 200 other teams. And one of my big things is that if you want to improve the health and well-being of a population, you've got to have population building blocks. And what we got with all these teams is that we took the geography and you map them against the geography. You'd have, you know, district nurse teams in this footprint, this footprint, physio like that, OT like this, the practice is all dotted around. We don't actually map onto and look after the same population. We do, there's lots of crossovers and so on. We've got all these different teams, and the other thing that, again, I'm talking as a doctor, but I sit on the Alliance in Cumbria, the different programme boards, the Better Care Together for Health and Future, the big strategy boards, went down to present our Vanguard bid, which was successful for across Morecambe Bay. But on none of those meetings is there a nurse or a therapist, and what you've got is you've got doctors and managers basically. So I think it's time for the nurses and therapists as well. I'm saying this to a similar event amongst the OTs. The OTs got together from the County Council, the Acute Trust, and the Acute Trust and the Partnership Trust. And basically I was trying to suggest that they really need to think of themselves as a group, as a professional group, and get a stronger voice in the emerging models of care, the new models of care. So one of the purposes of getting together here is that you need to think as a nursing group how you strengthen the voice. The federations are an opportunity because now general practices are joining together and so on. But then we've got, I don't know how many hundreds of community nurses, about 400 I think. There's a lot of nurses, and pull them all together, you've got quite a strong voice. And we've got, I don't have to remind people about the pressures. Massive, you know, major incident in North Cumbria. We're sitting in Gulf Command, Sally and I, on before the weekend. Admissions increasing, hospital admissions increasing. They did go down for 3 years in Cumbria. It went down 14% when about 2006 to 9 or something we went down. But since then they've been back on the increase again. Contacts in general practices went up 21% in 5 years. And it feels like that. I still do some general practice, and my wife's a GP still. And you know, I talk to all our nurses. It feels like the pressure's just going ramping up and up and up and up. And over to 85s are doubling in the next 20 years. Dementia cases, because Cumbria is the oldest part of the northwest by a long way. Dementia cases are going up between 4 and 5% a year. So see went to last year went up 4-5% dementia cases. This year they've gone up 4-5%. Next year they'll go up 4-5%. Think about that, that's 15% more dementia patients in 3 years, and that's going to go on for 20 years. And the district nurse teams are under a lot of pressure. We did surveys that showed that the dependency of the people we look after in district nursing in Cumbria is about twice. The ones on dependency level 4, which is the most dependent, and level 1 was the least dependent. The level 4 was about twice the Scottish average, and level 1, least dependence, was about half the Scottish average. We've already shifted a lot of care out of hospital and looking after very dependent patients. And what we've got is this phrase, the system delivers, I paraphrase it really, the system delivers what it's designed to deliver. So the system at the moment is delivered, when you put more pressure in it, to end up in major incidents and stack up people in A&E. And because we haven't got a properly organised out-of-hospital care system, what we've got is this. And it's not quite as bad as that, but there's lots of good collaboration and good functional teamwork, but the design isn't like that, and the team working tends to be workarounds around the way we designed it rather than as part of the design. And this is one of our problems. This is the population in Cumbria, and you've got this bulge, and this is similar nationally as well. There's people born in the 1950s and 1960s, this bulging population here that's coming in towards into old age. So it's a baby boom, and once you get beyond that, it will then flatten back down again. So we've got like a bulge in aging, and it's partly this bulge, and it's partly that people are living a bit longer. And the life expectancy, when people are living longer, that's made up of people living longer in good health and longer in ill health. So as the life expectancy has gone up in the country, it's made up of, it's not just good health that's got more, it's living with multiple long-term conditions and time spent in ill health that's got higher. But putting that demographics into what's going to happen, and this is partly why it feels so busy, because we're getting all these things increasing. You know, this is dementia rates going up really dramatically in Cumbria, and nationally, but particularly in Cumbria because we're the oldest part of the northwest. And this slide, some of you have seen this. This is a study from Scotland, and it was looking at multimorbidity. So it's essentially looking at people with these conditions. So that's heart failure, the top one. The light blue is a chance of just having that diagnosis. The dark blue is a chance of having 3 or more other long-term conditions. So if you've got heart failure, you've got 3% chance of having that as a single diagnosis. You've got 74% chance of having heart failure plus 3 or more other long-term conditions, and that's what we're seeing. So we're seeing the oldest old with multimorbidity. So age itself isn't the issue, it's age plus multimorbidity, and frailty in particular is the issue of people becoming more and more frail, so functional decline, presenting hyperacutely and ending up in hospital, and we spend all the money doing that. And what we need to do is to spend some of that money into more building out of hospital care system. So what we've been doing traditionally we're just pedalling faster. That's the system response to these challenges so far. And what I'm going to describe to you is that we need to begin to move into different ways of working together and collaborating. Most of what we spend in the pie, in any town's pie, is in this chunk going up to the hospital. It's usually doing things people don't want to do. So if you're an older person with frailty or you've got dementia, 2/3 of people with dementia live at home, get onto that conveyor belt and take it into hospital, you've 40% chance of not coming home again. So the thing is to stop them getting on the conveyor belt. Because that's where all the money, most of the money is spent in these high cost areas. So we need to shift the paradigm, and we need to, this is something that Kingston have been talking about recently, moving from fragmented care through integrated care, so working together much more into a population health system. So by working together collectively as public servants with our populations and communities and with the public, helping mobilise public into some sort of a population health system, where we can go upstream and spend more of the money on the preventative stuff, more in the out-of-hospital setting. To finish, I'll tell you a little bit about primary care communities, which most people have heard the concept. Primary care communities are the place we come together. So they are where we work together collaboratively, so general practice, social care, community services, with the community assets and the sector. And we come together for two things: to continue to give the individual care, which is what we all do, but begin to take a population view of it. But primary care communities are built up from practice lists, so the clusters of practices. By building them up from practice lists, you've got a population. So you can begin to get a population health approach. The population health building blocks, so that's the number one thing to think about with primary care communities. They are mapping ourselves, sorry, it's got a bit corrupted this picture, but it's mapping our teams onto the same, not the same geographical footprint, but the same population, and as much as possible onto the same geographical footprint. So in Allerdale, there's 5 sub-localities, 5 towns, obvious, those are your primary care communities. And within those, what we want to do is get rid of waste and all the handoffs and extra processes and so on that we do. And then over time to get to a devolved budget for these building blocks. And the design really to do that shift of care outside hospital. So we've got to, the future is that despite us being under massive pressure, we've got to take even more care outside hospital. So we need to influence that pie spend and get more of the pie spent in the out-of-hospital care system in general practice, the wider primary care setting and community services. And we need to work with the third sector, a lot of the things that everybody's doing, care plans for self-care and so on. The 5-year forward view, if people haven't heard about it, was published in October, and it started to talk about new care models. And these are cutting across the current organisational structures. So the 2 big ones are primary acute care systems, which are joining up hospitals, community, general practice into some sort of collaborative approach to delivering the system, and multi-special community providers, which are more community and general practice groupings working together. Then we've got into that mix of emerging GP federations. But the future is much more partnership working. So they you know, if someone's asked me where are we going, I think we're going into more collaboratives and partnerships and so on. And primary care, general practice is organising, which is really good, but into its federations, because that then gives a sort of grouping that we can then partner with at scale. So certainly community services and general practice are on a convergent path, which doesn't mean that district nurses will suddenly have to do things they shouldn't do, or practice nurses won't be, keep the focus on long-term condition and chronic disease management, all things to do really. One of the reasons for this event is we need to start to think of nursing as a professional grouping to get its stronger voice in all this churning, changing systems, new models of care. because I can see it, that the nursing voice and therapy voice isn't there enough in the conversations that are happening. And if we don't get it there, then what will happen is you'll have GPs and others design things for and it won't work. No, it won't be. It's got to work on it.